And thank you very much. I again am really thankful to be here. It's actually, I think, going on since 2004. So going on now the 8th or 9th conference that we've been able to share with Nancy, and we've done it as a group. And I think you're really fortunate. In fact, you know, what you've heard, from both Don and David just a little bit ago is not what you hear when you, survey and what you see around the country. And so, what they've started with the Thyroid Center, and I'm going to talk a little bit about optimizing therapy and working as a team, that's something that's not really been well done in anywhere in the country. And so really, the residents of San Diego are very, very fortunate to have them in town, and certainly also with the other centers that have started. And I'll kind of show a little bit about our take and how I think we can move forward and what other therapies are there and are available. Just as a show of hands, who has eye disease, if you don't mind? Okay, so a fair number of people. And I'm sure you have lots of specific questions, but I'm going to get started about picking up a little bit upon where Dr. Rose and Dr. Smith left off, but also and then highlighting some of the points of Dr. Granite and Dr. Kakawa, in that what we're dealing with is a systemic autoimmune disease. It's a disease that affects the entire body. It affects the skin, it affects the eyes, it affects the thyroid. Why we think of it so segmentally is really just a function of our medical system. It's a function of how we treated patients 200 years ago. It's not a function of the disease. And so one of the things that you've heard throughout this conference, which does not really get as much press nationally, is that we should really be thinking of the patient first. And I'm going to talk a lot about, and Don and David already have, of how you can think about the patient first through the entire process of this disease. This is a slide that I show quite a bit, but it is very important to show that you have a disease that essentially starts off and then progresses over several years, increasing in severity. Disease where you have, and I'm sorry that the reds don't quite show up on the screen as much as we'd like. It may be a little bit hard seeing the before and afters, but you can see that this disease worsens in severity and then plateaus as far as the eye disease is concerned. And what we've really been focusing upon in the laboratory, and Dr. Smith has been working on for the last 20 years, and Dr. Rose also in autoimmunity in general, is finding ideal immunomodulatory therapies that can prevent the downstream consequences of this disease. So that when you're diagnosed, or that we can identify the disease, hopefully before you notice any manifestations, that we'll be able to predict who's going to get the eye disease and have a therapy that's given shortly thereafter. And I don't think that is science fiction any longer. I think that we're closer to that, and working as a team in a combined approach is actually, I think, going to be something that will be achieved within the next decade or so. But I'm an optimist. We can also know that this disease, and Dr. Kakawa mentioned a little bit early, in some forms, in heterogeneous forms, early surgery may be beneficial, may actually help to calm down this disease. Really, the bottom line that I'm getting to is that this disease is different in every person. Your disease is different than the person sitting next to you. It's a disease where the immune system attacks the entire body, but it manifests itself very, very differently. Just as I look very, very different from Dr. Smith, I think all would agree that he's a strapping, young, handsome guy. But we look differently, and so the disease will affect us differently depending upon both age of onset, but also our genetics and our predisposition. So what do we need to know? Well, we need to know it's an autoimmune inflammatory disease with a lot of fibrosis, and that gives us an idea of how to prevent this. How do we get permanent facial disfigurement, which you've just heard a lot about, and we have no treatment to prevent the disfigurement, and our standard of care is wait and watch. That's a pretty dismal list of 4 points. But I will tell you where we're making progress and what options you have, because we are making progress in various aspects of this disease. So let's define optimal care. And we've taken a step back, and we saw Don's model that he had set up, and when we moved to Michigan, we wanted to define optimal care, and that really means a patient-centered approach. And I'll talk to you a little bit what that means and what implications that may have for how you're being treated. And then education, both education of the patients and physicians. Education in forums like this, and forums where we've started in Ann Arbor on a quarterly basis, but also education of physicians so that physicians work together and we can actually develop the research and clinical tools to really make a difference in this disease. And then research, and I'll tell you a little bit about some of the research that I think will make an impact in identifying this disease early and treating it. So we often think about these spheres or these missions when we start to think broadly about healthcare, about patient care and education and research and how this fits into our community. But what we're really trying to think about is, and really develop a model, is how we can bring these together, how we can combine both patient-centered care, educate the patient and physician, and provide a tool for research so that we're not stagnant where we are and just delivering information, but we're actually creating wisdom and knowledge. The creation of wisdom is very different than the creation of knowledge. Than the creation of data. We can tell where things are and identify and catalog, but what we want to do is begin to define where this disease and change the outcomes of this disease. And I think pulling those spheres together is the most important thing. Our patient-centered idea really started with an old referral paradigm. And I like to, instead of David's example, I like to use a little example of my own, where the patient just bounces from specialist to specialist, just not between one eye doctor to another. The fortunate part about the eye doctors is that we're just down the hall. We can at least communicate a little bit. The problem is, how do you talk to the endocrinologist? And then if there's someone who's really has severe problems, how do you talk to the rheumatologist? And what about the thyroid surgeon? And they're hard enough to get into a room together like this and confine them for long enough periods of time. How can you get disparate specialties? Medicine has created these silos where we no longer speak to each other, but we just carry forth our own little silo and make sure that our own little world is fine, but we don't communicate on the basis of providing patient care. And so one of the things that we decided we had to do was to place the patient in the center. So we've created a system that not only works within ophthalmology, but Dr. Smith at the University of Michigan is on staff as an endocrinologist in the Department of Ophthalmology. That doesn't happen anywhere else, but hopefully that is a signal that what we're doing just doesn't work, and we need to talk to each other. We also have conferences where each one of these people representing their specialty talks on an individual basis about every single patient that we see for thyroid eye disease care. So our goal was really to engage patients early in this disease. Let's not wait till you get the eye disease. Let's identify you when you were first diagnosed. Let's see if we can't figure out why you developed Graves' disease, and possibly even in studies. Let's give you the option of meeting with someone who does radioactive iodine, thyroid surgery, or medical management before you ever have or develop eye disease, but as part of your initial treatment. And so that's been our team and our approach. And some of the things, this is just an example of our center, and these are the people that meet right now on a monthly basis and talk about all the thyroid patients that we see during our thyroid clinic to offer their opinion, and they come from all different specialties. The idea is that we give a patient-centered or concierge approach, that referral patients are called and interviewed, we arrange all the subspecialty appointments, and the educational information is sent to patients. This is really, and how it boils down to you, I don't want this to come across as this is what we do. This, how it boils down to you, this is what you should be expecting and hopefully getting in your treatment. Because if you don't, it's going to be very, very hard. You're going to be the one bouncing from all of the other subspecialists, and you have to try to make the connections. And I know in places where the centers are not available, it's very hard, and sometimes you have to do that. But at least, hopefully, this gives you a blueprint of the different people you have to bring together and get them to talk. And then, and try to be seen in certainly in a timely manner, and that's one of our goals also. So, is it optimal? Well, it's still a work in progress. Right now, we're trying to coordinate the endocrinology management with the orbital specialists, and we've learned some things about moderate and severe disease, surgery in the active phase, and even early intervention, for non-progressive disease. But we're still working to really fill in this model. And so what I'd like to talk to you a little bit about is to break these down individually as to what they may mean for you. First, let's look at research and what research is going on that might make a difference for you. how many people, in the room really care about research? I really always thought that patients would be more concerned about what happens to them than research going on in the field. Absolutely false. Patients are more concerned about research, I think, and how they can help other people in the same situation than they are often about their own situation. Patients come to our center sometimes just to participate in studies. They could get their care elsewhere, they're fairly stable, they're doing well. They come to participate in studies. The patient always asks us in our conferences, what new research ideas are being developed? How can I prevent my son or daughter from getting this disease? How can I potentially help by donating blood or doing other things to help prevent this? And so I'll give you at least an update as far as our research and some of the other things that are going on that you might hear about in the press and that might be offered in the relative near future. First is that we really think that this disease comes from a very early progenitor cell, a stem cell from the bone marrow, which then goes on and differentiates and can do a lot of different things in the body. And I'll show you some cartoons of how we think that might happen. But we've always had the conundrum as to why someone's thyroid gets affected, why someone's eyes get affected, and they happen at different times and different muscles, and some people get more skin involvement. So how do you put that together? Well, one of the questions that was asked in some of the other lectures is, well, why does that occur? And one of the reasons maybe is that we're really viewing this again, just how medical system has been structured to think of the individual organs, but we really should be thinking of a systematic approach. One cell or a type of cell that can migrate to various parts of the body and control the immune system, and also not just control the immune system, but can differentiate into one of these scar-producing cells or modulate the immune system. The other aspect of the research that we'll talk a little bit about is how we can stop that disease early. And one of the ways that will be coming to trial is trying to block the receptor or the autoantigen, so to speak, that may be responsible in this disease with an autoantibody so that your immune system doesn't stimulate it. It'll be the first trial in this disease, and I think in autoimmunity, but I could be corrected, that will really target the underlying disease, the specificity that we've always been missing. And so hopefully that will allow us to make some strides. And then we'll talk a little bit about some of the non-surgical management too. But what does the healthy immune system look like? Well, you have a bone marrow, and from your bone marrow comes your immune system. Your immune system starts off in your bone marrow and as an adult and spreads and surveys your body and tells you when there's something going wrong and what defines you. And what it does is some of these cells, and these are a specific type of cell that we think are to contribute to this disease, they survey various tissues. And then when they come across something that looks like an infection, they can proliferate, they can then begin to modulate this infection, and then eventually form a scar. And we think that the cells that come from the bone marrow, we call them fibrocytes, but it's a bone marrow-derived cell that has the capability of not only surveying various tissue sites, but also causing an immune response and then causing a scar response. Well, inflammation and scarring, if you've been asleep even for most of the conference, you'll know that inflammation and scarring are pretty prominent in both the thyroid aspects of the disease and the eye disease. So those are two things that we think are very important. So what do you think happens in Graves' disease? And we have data to actually support this, but it's much better to talk without data because data just confuses things. No, I'm just joking, but hopefully this will at least give you an overview. Well, we know in Graves' disease that these cells are present in a much, much higher number. They appear to be similar, but they're just present in a very high number. We've done a study in quite a large number of patients showing that they're increased in number and that they also even appear far after the disease has been present, 20 years after the disease. And so what we think they're doing is that they're surveying and potentially misrepresenting or misidentifying something in the orbit or the thyroid, and then beginning to proliferate and potentially infiltrate these tissues, causing the disease. This is just an eye where these cells are coming in and producing what's called cytokines that promote the inflammation, but then they can also turn into cells that produce scar. And we think that this is a very important part of the process, and that identifying these cells will help us to really understand not only the disease, but also possibly to predict who gets this disease. So what can we do to stop the progression of the disease? I don't know who asked that question right before I cocked up. That's the spot-on question that we've all been wanting to answer, but in some ways afraid to ask, because asking that question really exposes our lack of knowledge. So we don't know. That's the bottom line. So, and the other question is, well, why bother stopping the disease if we can just do surgery to reverse it anyways? Well, the answer to that is that the surgery doesn't reverse scarring. The surgery doesn't reverse muscle swelling. It may make things look better, and I can make you look a lot better, but it doesn't reverse the underlying effects of the disease. So it is a very important question to ask as to what we can do to stop the progression of the disease, and there isn't much, but there are a few new things. One is, again, we're looking for immunomodulatory therapies early on in this disease. And as an aside, I'm not going to talk about it, selenium has been shown in some early studies not to block the fibrosis, but potentially to help with early onset eye disease. It is by no means proven, but it is one of the things that has been shown that may help to minimize the eyelid findings in this disease. Steroids, no matter how high a doses you give them, the most you can detect is an itty-bitty change in the double vision. Probably not even enough, and David's not here to give Botox. Very, very little change, considering the doses you have to give can cause death via liver failure. So a huge risk, in my opinion, and recently speaking with the Europeans, there's disagreement, but a huge risk for almost no benefit. I do think they make people feel better, but they don't make the disease stop progressing. They don't change the natural history of the disease. But we're looking for a specific immunomodulator that may, and we'll talk a little bit about others. So this is, what I'd like to show you is going to be a video. And it's of a patient, a normal patient, and their eyes moving around. And this little area right around here is the optic nerve. And you're going to see this little baby disc swinging all over the place. The eyes are moving. And then we're going to show you an MRI while the patient is looking from side to side who has thyroid eye disease. And so the reason for showing you this, and why I'm going to tell you why I'm showing you this, is that I want you to see the difference as to what we could do if we could stop the progression of this disease. From the outward appearance, we can make the person with thyroid eye disease look normal, but we can't make them look like they never had the disease. So here, I hope this works, but now that I've given you the build-up, watch it not work. Yeah, I was afraid of that. Can I, how do I'm not used to getting out of this one. Escape. Okay. Just give me 1 second. I've given you the build-up. I can't possibly let you not see it. I thought for sure that if I brought up my Mac that it would all work. So this is the MRI. These are the optic nerves swinging from side to side. This is the MRI of someone looking from side to side. Okay, and you can see the muscles over here are moving quite nicely, but the optic nerve is just like this little tether, this little rope that's being connected to the back of the eyeball, moving all over the place. Let's contrast that with what happens in thyroid eye disease. And I hope this is projecting well. I apologize if it's not. What you can see is this nerve doesn't move. It just really doesn't move. So this muscle is so large right here that the nerve is pinned in place. And so then you wonder, well, how could you develop nerve impingement or optic neuropathy? Well, because the muscle is so big, it's squeezing the nerve and it's barely even moving. So this is a good example as to what happens. And if anyone wants to see this, I'd be happy to show that to them after the. This is why the disease, one of the things we want to do is to try to prevent the progression or the onset of this disease. So have we made any progress? Well, we've concentrated on the immunotherapy, and not specific immunotherapy, but at least specific to a cell type. And one of the drugs that Dr. Smith and I have a fair amount of, I don't want to say experience with, because no one really has a lot of experience, but at least we've utilized these drugs in select cases. There's a drug called rituximab that is an anti-B cell drug. And this is not a drug that should be used for everyone. It's probably not even a drug that should be really used off trial, because there are a couple of trials that should be coming out with data saying how effective this drug is. But it is a drug that seems to be very effective in certain select cases, and that eliminates a cohort of B cells. It does not eliminate the antibody, and I'll show you some data for that, but it eliminates B cells that are probably promoting this immune response. And it's a monoclonal antibody. It's delivered in just 2 infusions. And we're just learning, but it probably has to be delivered in very low amounts. And it causes the B cells to go away. And then it probably acts, we're unsure exactly why it has such a dramatic effect, but usually it's like an instantaneous off switch. We've used this and published a trial where we looked at patients who were very, very severe, typically losing vision, and who were unresponsive to steroids, and found that it had actually quite a large effect in reducing both the clinical activity score and stopping the disease progression. And this is just an example of a patient who had this drug and was after. Her bulging of the eyes, we gave this to her late in the disease course, not the ideal immunomodulatory. This was a salvage case where she was going to have to go on to quite a bit of surgery and other things that we weren't sure we could stop the disease before she went blind, but stop the disease in its tracks. And it appears to have done that probably in about the 50 or so cases of which it's been done. And again, there are 2 trials that should be coming out within the next 6 months or so to really help us, guide us as far as the treatment of this. And we are proposing a low-dose trial of this drug. So does it change the antibodies? No, we don't exactly know, and so it won't change the TSI or the TRAb. When we don't exactly know the mechanism of action that provides such a fast clinical improvement, is probably from the presentation of antigen and the immune system as it has to work together. Again, this is a non-specific immune system blocker in that it's not specific for Graves'. This drug has a huge history in rheumatoid arthritis and is typically first line in that disease. So what about drugs or developments that you may hear about in the next couple of years that are specific for thyroid eye disease? Well, one of them is looking at and trying to block the insulin-like growth factor 1 receptor. This is a receptor, IGF-1, that Dr. Smith has worked with for many, many years. When I joined him in the lab, oh my God, I guess about 15 or so more years ago. And he has done a tremendous amount of pioneering work with this and identified that as a potential autoantigen in this disease, where there are autoantibodies to this receptor in addition to the TSH receptor that may be driving the disease progress. And he just showed me an abstract just now looking at how these 2 receptors cooperate, which we've shown in the lab a little bit ago too, both the TSH receptor and the IGF-1 receptor. Well, it turns out that this receptor is far more frequently expressed in Graves' disease, not all autoimmune diseases, but especially in Graves' disease. And here we showed on the T cells. It's also been shown on the B cells and on the fibroblasts that we've shown in the lab some time ago. And so one of the things is this appears to be a signature marker for the identification of the immune system, potentially immune system aberrations that are going on. Well, why do we think this works? Well, one of the things we think that happens is that normal T cells would just normally die. They wouldn't receive a positive signal to live. You don't want T cells running all around. If you have a virus and your white cell count goes up, you want that white cell count to go back down. You want your cells to die off. Death is not a bad thing for the immune system cells, because when something lives too long, it can turn into cancer. So the normal process for an immune cell is often to die. Well, what we think happens in some of the Graves' T cells is we think that the antibody may help to stimulate this receptor and actually have an expansion in what we found a memory T cell population. We found this in both our normal subjects, and we've also done a twin study in Denmark finding that a certain populations of T cells are increased that express this particular receptor. And so the idea is that if you can develop an antibody that would block this receptor, and block all the downstream signaling and the production of cytokine and the influx that this is causing, hopefully you would block all the downstream reactions thereafter and prevent the infiltration of the other immune cells, if given early enough in this disease to prevent the downstream manifestations of the disease. And so this is coming to trial. It will be investigated as a blocking antibody in Graves' disease, and the enrollment will just be starting up. It'll be the largest U.S. trial, and I know that there are about 20 centers throughout the United States, and so it is something that you may hear about as it develops. But just to at least give you an idea, and this won't apply to everyone, it may not even apply to anyone in the room to participate in the trial, but at least so you know where research is headed and where we are looking to achieve results. So I just want to switch gears just in the last few minutes as far as how we can begin to think about not just individualized specific treatment for thyroid disease and the immune system, but how we can customize and individualize minimally invasive treatments for the people in here who raise their hands who have the eye disease. And here we go from what's in the future and what may be helpful to what is immediately available for you today. The goals here are really preservation of the visual function and aesthetic reconstruction. I think that Don and David said it, this is not cosmetic. I always use the term aesthetic reconstruction because we want to reconstruct things the way they were. This is a patient of mine. This is her high school photo or college photo, I can't recall. But I think that many people who have this disease will really understand the sequence of photos. And as she ages, normal aging process, but then as she develops Graves' disease. So I think everyone who's gone through that in this audience understands that transformative process that occurs in that small period of time. She aged 30 years between the first and second photo, and now within a matter of a few years, her looks and everything and the entire function has changed, in addition to getting double vision, in addition to being in pain from an eye pain. So what can we do? Well, one of the first things to do is define what people's goals are, old photos, bony structure, type of disease. And Don had kind of mentioned this, so I'm not really going to dwell on as much as I was planning on to, but there are different types of disease. And so one of the things you have to figure out is what type of, hopefully not you, but your physician, is to figure out what type of disease you have and what things may be better for you and recommended for you as opposed to the person sitting next to you who has a very different disease. It's an individualized approach. And one of the things, since you're going to hear about decompressions, I'm not going to show you a bunch of surgical videos. I did that the very first time I came here, and Nancy said, that was really great, Dr. Douglas, but I think 3 people passed out when you showed those surgical videos. So if you're coming back, you're not allowed to show any more of those. So I've learned. I now only stick to the before and afters and the non-surgical approaches. So what can we do in non-surgically? This is a woman with Graves' disease. This is a patient of mine. And she has not so severe Graves' disease. She's had this for a while. She's doing well. She's starting to notice the normal process of aging, some bags under her eyes. And again, I apologize if this doesn't show up as well as it could. From the side view, which I love side views better because it really gives you the 3-dimensionality of this disease process. You begin to see that her mid-face is declining a little bit and a little bit of puffiness. And one of the things we could say is, well, it's Graves' disease, just go home and you're just getting old. And patients have come to me and said, that's what my last doctor told me. I'm hoping you can tell me something different. And I do think that we can, because not all of this really is aging. The fact of the matter is that she had, that this disease really cause an expansion of the fat. It causes an expansion of the periorbital tissues, or meaning that if you put your hand right on your eyebrow, it causes all these tissues to get big. Your eyes open up more, so you have to frown all the time, and you get these nice big creases in the middle of your forehead because your eyes hurt, and then those muscles get big. And so it essentially changes the entire upper face in the appearance. And in some of my patients, it even changes their lower face. They have a boxier lower face after this disease. So this is not just normal aging changes, but one of the things we offered her was that we could do a non-invasive approach, meaning that there's no surgery involved here. All we did is take a little bit of Restylane filler, and in 45 minutes, I took out the one where I did it and just had it immediately after, and just one side of her face, but we did it just in 45 minutes, and this is the after. And so there's no surgery, there's no cutting, and so there are a variety of options. This option may not be right for anyone in this room. It may be right for many people in this room. The idea is that it's a customized process, and that the things that you can do is that there is always hope and there are always options. Many people come and say, I don't have any more options. There are always options. It just depends on a risk versus benefit. And again, just as improving some of the contours and improving her appearance, and that was plenty. That's all she wanted. This particular patient was too sick to have any decompression surgery. Her eyes bothered her tremendously, but was just too sick. So we had to do just eyelid surgery, meaning eyelid surgery to help to lift up the lower lid, not with a hard palate graft, which the more I do decompressions, the less I do, but I think they're reasonable, but just as a lifting surgery and an upper eyelid surgery. And again, with minimally invasive approaches, was able to achieve comfort. And here we weren't going for the ultimate rejuvenation appearance, we were going to improve comfort. You know, as she's on her CPAP machine at night and her eyes don't close, that's an uncomfortable situation. So what else can we do? We can do very, very minimally invasive surgeries where we take out a little bit of bone or a little bit of fat. And for patients, at least shown on the upper here, who had severe redness and just was always in pain, what we can do is give them a much more normal appearance and really dramatically decrease the amount of pain. And you can often operate on both sides at the same time in about 45 minutes and go home the same day under monitored anesthesia. Again, just another patient with a little bit of eyelid scleral show, a slightly better eyelid position, and again, a relatively small surgery. This is a woman, and one of the things I'd like to draw your attention to is not just her eyes, but also how, and beginning, and you can see down the cheeks, how her lower face changed with the surgery, or with the disease. And one of the things is that her overall facial changes in the fat and especially in the cheeks and the lower face, dramatically altered her appearance. And she was a relatively new mother, and this, in addition to taking care of a 3-year-old as she's coming into her appointments by herself and trying to synthesize all this, is obviously an incredibly emotionally taxing circumstance. A lot of times we do it in preparation for muscle surgery up top. This patient had double vision, and again, we wanted to move the eye back in preparation for the strabismus surgery and to give her a little bit of blepharoplasty to make sure there's an improvement. This is the patient that I showed you in the first slide, the transformation. Again, there is a nice improvement, but again, there are cases where there's just so much infiltration of tissue that you just can't take away everything realistically. She didn't even notice, believe it or not, she had gone on for about 10 years and didn't notice that her eyes have even changed. Her question on the exam was, well, I'm not sure, I know I have Graves' disease, but I was wondering if you think I have thyroid eye disease. And after an educational process, it became, yeah, I did notice all these changes and here's what I'd like to do about it. Doesn't mean you have to do anything, it just means that it's an available option. And just a woman who was very, very anxious to have surgery, but ended up having surgery and did very well. We're still waiting to do a little bit more eyelid surgery. She's not quite anxious to do that since she feels that she's good enough and I'm ready to go on my own and get out and do things. But you can do things where you move people's eye back but make them more comfortable, doing it in a customized and controlled manner so that you can achieve very reasonable results. And it's all dependent upon the patient's, what their goals are and what you're looking to achieve. This is, and I'll conclude this with, and then just another patient who, this is a very interesting patient who is already blind in one eye from an ocular problem where she had had a vein that burst essentially in her eye. And she was going blind in graves from in the other eye. And so what we had to do was emergency surgery, and then we just kind of fixed the eyelids, so to speak. And there's a little bit of a long platform, but she looks dramatically improvement, but we weren't able really to do bilateral decompressions because I really didn't want to operate any more than I had to on the eye and our only seeing eye. Just another example of the transformation process, and then I'll conclude. And I think everyone in this room understands the transformation process, but I think one of the things that always strikes me is that the person or that often accompanies you to these meetings, and kind of a show of hands, who's the spouse or the significant other or someone accompanying someone else here? Okay, so quite a few. In our quarterly educational sessions, it's about half and half. And so one of the things I like to show are these stepwise photos just to bring across what emotional toll it takes, both not only for the person, but for the spouse, and really thinking about how this disease progresses. Obviously, a very attractive woman who then developed the onset of Graves' disease and dramatically changed her appearance, and she was doing well. Unfortunately, she had surgery elsewhere and a progression of the disease, and so things started to go downhill. You can also see how big the cheeks begin to get with this disease. And that's, again, fat expansion, a little bit of fluid accumulation came to us, and certainly not terrible or severe, but really wanted to try to achieve an improvement in her eyes and a little bit of a lesser prominence. We were able to do that with some bone and fat removal, and I think a nice improvement. For her, it was a huge relief because of the changes and what had the strain that she felt that it put onto her marriage, and the additional emotional baggage that she was carrying and worrying about by her physical changes. And it was really nice to see that we could at least not only to help to modify that a bit. This is just the last patient I'll show, and she's one of my favorites people, just because I know her pretty well, and we've been down a long road together. And she speaks at some of our conferences, and her disease is tough because she is a very outdoorsy person. She gave up hiking, running, doing everything. And she's a position and a job where she actually works with her hands and has to, just can't get by otherwise. Single mother, has a 18 or 19-year-old daughter, and so a tough circumstance for someone who has pain all the time, double vision, and now has an incredibly different looking appearance. And so what we were able to do is, with some surgery, is to dramatically, I think, change her appearance. But not only the appearance change, that's not the important part. The difference that it made in her life is that now she just finished her first triathlon. She's now biking, she's now running, she's now swimming. I had to think about what the other third thing was. And so it was not just the change in her appearance, it's the change in her life that made the big difference. And so hopefully, just in summary, you'll see that this is a heterogeneous disease. We think we have some insights as far as the research that's going on. And hopefully I've at least talked to you about some of the less invasive options that are available for those with eye disease and what they can mean and do for you and your family. Thank you very much. It's always a pleasure. Sure.
And I'd like to get the adapter back.
Sure. If people have the enthusiasm, you can ask me a couple questions, or you're welcome to walk up and you can enjoy your coffee too.
All right. So it sounds like, we do have a question here. Can I go ahead and remove this?
Thanks.
I was curious, is Actemra an IGFR?
What's that? I'm sorry.
Are you familiar with Actemra at all?
I don't know the trade names. What's the actual blocker?
I couldn't tell you. I guess that's what I'm asking.
Yeah, I don't believe it's IGFR. Actera sounds like a drug name. It's something, oclusamide. It's a rather longer and a complex name.
Would rituximab be the same thing as Remicade?
No. No, Remicade, again, that's the drug name, which I'm much more common with knowing what the actual generic names are, but Remicade, I believe, is a TNF alpha blocker, yeah. And so, again, blocks different things. The TNF alpha blockers, both Remicade and then infliximab, Humira, they've been used in a case study or two, but TNF alpha doesn't seem to be quite as prominent in the disease pathogenesis, at least from what we've seen in the laboratory.
There are other cytokines that now have been targeted using monoclonal antibody technology for therapies in other autoimmune diseases, rheumatoid arthritis, psoriasis, scleroderma. These cytokines that have been targeted include something called IL-6, the IL-6 receptor, and IL-1 beta. And we have a great interest in seeing if we can repurpose some or all of these drugs for Graves' disease. We think that at least theoretically there's a great promise there to alter the natural course of the disease. And as Dr. Douglas has just introduced the concept of blocking the IGF-1 receptor, which we're doing ourselves.
Yeah, it's a hard discussion to have because these drugs have significant side effects. So you have to think of repurposing a drug that has significantly lower side effects. It's not a drug necessarily that would want to go out and test from the beginning in a self-limited disease, a disease that probably will not kill you. So, but the drug could. And so you have to be very, very careful in thinking about these immunotherapy drugs. Sorry.
Couple of questions. Just antioxidants or just like a holistic approach to health, does that have any impact on the symptoms that you would be experiencing in the active phase? And then the selenium that I saw mentioned said it was at the early stages was the most effective. Is it not effective later?
So there's one of the problems with Graves' disease is that we don't have great studies, and one of the reasons we're forming centers and trying to get enthusiasm is to actually conduct those studies. So the selenium trial is an antioxidant, and it's it was done in a European trial scattered throughout Europe. Selenium also has a variety of other potentially immune modulating functions, and I'm not implying that that's the mechanism of action. In that study, selenium was given to patients with mild disease in the early process of the disease. And in that study, it was shown to have a small, but at least a measurable improvement in the quality of life and in some of the soft tissue changes, meaning the redness and swelling of the eyelid. Their study did show that it looked like at least there was a trend toward being better taking selenium at the end of 1 year than if you didn't take selenium at the end of 1 year. Though that was a little bit harder a little easier to overinterpret, I guess would be a better way of putting it. So as far as antioxidants, the best data we probably have is with selenium. It doesn't mean that it's non-effective later on, it's just that we have no idea whether it is. We wrote a review of that paper. There are other caveats, but at least selenium is relatively inexpensive, and it doesn't appear to have dramatically harmful side effects, at least if taken in low dose. The most important thing is making sure you don't come in contact with smoke. That's the one thing that we know makes the disease worse. It makes treatment harder. It makes every aspect of the disease more difficult to deal with. As far as holistic approaches, again, there haven't been any studies to suggest that. One of the things, though, I think is that if you feel that you're living a healthier life, thinking about exercising, and it's actually putting you more at ease, it might help your mental state of mind, which if it doesn't help your disease, at least it makes you feel better. and it's not a trite answer. It's it may be really how you feel about the disease is as important as anything, because there just are no studies to guide us in that.
One more question?
Yeah.
I understand trials and studies, but I was wondering, is there any central place that, like occulofacial surgeons report, I tried this and it really worked well, or this didn't work well at all? Is there any report within the profession? Is there anywhere where surgeons can learn from each other?
We try to learn as little as possible. And we do a very good job at it. It's just hard to know because the disease is so different in so many different people. And I'll come to the meeting and I'll say, this really worked well for me. And there always are take-home points that you learn from other surgeons, but it's a very incremental and a process that has a lot of random motion. So you go into a lot of directions that may not be leading you anywhere. And so one of the things is that we've not done a good job is putting together studies, even small studies that could have a collective experience. But absolutely, those studies appear in our journals and have helped to shape what we know today. I mean, we know, and the reason why we treat with a staged approach of decompression and many of the fundamental assumptions that we make are formed by, not by studies, but are formed by people's experiences. Hopefully the next step or the next future will be, instead of making all this little incremental progress, and I honestly think that surgery, except for getting smaller and a little more refined, we've maxed out. In the last 30 years, it hasn't changed. I mean, we're doing things a little bit differently, there's some nuances and everything, but it is where it is. It'll get smaller, easier, you'll go home faster, it may cost a little less. That's not a change that prevents the progression of the disease. And so hopefully we can begin to think collectively instead of just these small reports. But yes, they are published, and so they are available.
Thank you.
Thanks.